Thank you so much. Thank you so much, NCAN, for the invitation. It's an honor to be with you all today. We're a small group, so please feel free to interrupt me and ask any questions. So I just want to make sure that all of your questions are answered. So I'm here for you. So in the fact that we are a small group, so I'm all for you in any of the questions that you may have. So please feel free to interrupt in the middle. Just raise your hand and ask any questions. So I'm going to discuss about cancer predisposition syndromes associated with neuroendocrine tumors, but the focus of the today is mainly on multiple endocrine neoplasia as well as FEO, chromocytomas, and paragangliomas. So one of the questions that my patients sometimes ask me is my tumor can be familial? So, and there are concerns because sometimes they say, well, I'm concerned because I don't want my kids to have it. So usually my answer to that is that most of the neuroendocrine tumors are sporadic, meaning that we don't know where it's coming from. At the same time, there is not a familial condition associated with that. However, and that's what I'm mentioning here, approximately 10% of all neuroendocrine tumors may be associated with familial syndromes. You also learned, and you will learn throughout the meetings, that neuroendocrine tumors can be anywhere in the body. Most commonly is found in the lungs, as well as the GI tract, and also we have the pancreas as well. But just to mention here, if there is a neuroendocrine tumor of the thyroid gland, that's cause medullary cancer, and thus this cancer predisposition syndromes associated with that is multiple endocrine neoplasia type 2A and B, and we're going to discuss a little bit more about that. If there is a familial condition associated with lung neuroendocrine tumors, and again, we need to keep in mind that most of the time are sporadic and less than 10% or about 10% are associated with familial syndromes, that will be MEN1. So just to let you know, a patient that has a thymic or is diagnosed with a thymic carcinoid, we need to screen for MEN1 or thymic neuroendocrine tumor. Pancreas, there are different cancer predisposition syndromes associated with pancreas neuroendocrine tumors, such as multiple endocrine neoplasia type 1, bronchial NF1. And we're going to discuss a little bit about the FEO, chromocytomas, and paraganglioma. So this one is the most familial of all neuroendocrine tumors. Approximately 45% of all pheochromocytomas and paragangliomas may have a germline pathogenic variant. So these tumor or neuroendocrine tumor, which is very rare, is the one that is associated with different cancer predisposition syndromes. Now, we're not going to talk about it today, but there is a very small percentage that small bowel neuroendocrine tumors may be associated with familial carcinoid. And familial carcinoid are the ones that have multiple primary small bowel neuroendocrine tumors throughout the tract, the GI tract, and also we have a first relative associated with that. So that's kind of like one of the criteria to think that maybe someone may have a familial carcinoid. So this is just a difference between multiple endocrine neoplasia type 1 versus the type 2A and type 2B. So we're going to discuss more in detail. Multiple endocrine neoplasia is associated with the 3 Ps, pituitary adenoma, parathyroid tumors. Usually those are benign, and then we have the pancreas neuroendocrine tumors, and we're going to discuss about it more in detail. And these are just to show you the difference between MEN1 and MEN2A or MEN2B. We're not going to talk about this, but just to let you know that patients that have multiple endocrine neoplasia type 2, which is different than type 1, may have medullary cancer or may have a pheochromocytoma, and those are neuroendocrine tumors as well, and these are more rare. But we're going to discuss more about the MEN1 today. So now let's discuss about what is MEN1. MEN1 is a rare familial condition that predisposes to tumors in different endocrine organs. Those endocrine organs can be the parathyroid gland. So initially, you will discuss more in detail that MEN1 is characterized for the 3 Ps, which is pituitary adenomas, parathyroid tumors, as well as pancreas neuroendocrine tumors. But what we know about MEN1 is it can be associated with other neuroendocrine tumors, such as the lung neuroendocrine tumors, thymic neuroendocrine tumors. Now, patients with MEN1 may have a higher increased risk for breast cancer, so we need to screen for that as well. And we'll discuss more in detail. And there are other clinical findings associated with MEN1, like some skin findings like lipomas and collagenomas, and of course we'll discuss more about the gastric and pancreas neuroendocrine tumors. This MEN1 is associated with a germline mutation. When we say germline, it's because it's everywhere in your body and every cell in your body, and there is a chance that you can pass that genes to your kids. So that's why this is autosomal dominant. Autosomal dominant meaning that there is a 50% chance that your kids may have these mutations, and because of that, they may have MEN1 or may have this presentation with associated different endocrine cancers or endocrine tumors. And the germline mutation is called the MEN1 gene, or we also call it menin. Now, patients with MEN1 can develop hormone secreting as well as non-hormone secreting tumors in the endocrine organs. So what means by hormone secreting is that we'll discuss more in detail. They can secrete peptides, hormones, and based on what hormones they produce may have a very specific symptoms. And we discuss about the 3 Ps, which is parathyroid, this is the most common clinical presentation associated with MEN1. We have pituitary tumors as well as pancreas neuroendocrine tumors. They cannot be non-functional. Another word is non-secreting. Yes. That's a good question. And yes, sometimes we see those tumors that can differentiate, meaning that they can change on how we look under the microscope, meaning they could be well differentiated, and then over time they can become a little bit more aggressive or more. That can happen. Not very common, but it can happen. Right. So, and that's another very good question. So when do we have an indication to do another biopsy? Because you're right, most of these tumors, as you say, they stay stable over time. But if we see like a change, a rapid growth. Okay. No, that's okay. Okay. So, and that, if we have, and then we have Dr. Wallen here, who is a neuroendocrine tumor expert. So thank you so much for being here. He's the world expert in neuroendocrine tumors. So I'm so honored that he's here today. But, yes, so, and if we see like there is a dramatic change, that's when there is indication to do another biopsy just to see if that happened. So then we discussed about the 3 Ps, but parathyroid tumors, pituitary as well, pituitary tumors. Most of these tumors are benign. Often they can produce hormones, and the most common hormone that the tumor may produce is prolactin, and that's the reason why it's called prolactinoma. So prolactin is a hormone that is needed for lactation. So in those situations when there is a prolactinoma, you may have some signs of lactation as one of the symptoms as well. Then we have the pancreas neuroendocrine tumors that we discussed. Most of these pancreas neuroendocrine tumors are non-functional, but we have the ones that can produce hormones, and we'll discuss more in detail what the hormones they can produce. More commonly, an MEN1 is gastrin, so any patient with gastrinoma also needs to be considered or screened for MEN1 as well. And then we have other hormones that is produced by the pancreas. There are other tumors associated with neuroendocrine tumors. Yes? Usually, whenever there is a functional neuroendocrine tumors, we see symptoms associated with that. And we'll discuss more in detail about that. If there is a pancreas neuroendocrine tumors that is producing insulin, you will have the symptoms of very low glucose, hypoglycemia. You will have symptoms associated with very low glucose. You have a tumor that is producing gastrines, and then you have the ulcers. There is an increase of what we call peptic ulcer disease and so forth. But we'll discuss a little bit more in detail about that. And then, as we discussed earlier as well, there is multiple patients with MEN1 may have an increased risk to develop breast cancer compared to the general population, so breast cancer screening is recommended as well. So now let's discuss about what is primary hyperpara, because sometimes my patients may say, you know, they have multiple endocrine neoplasia. What does that mean? How do we treat it? So parathyroid gland, so this is your thyroid gland. And on your thyroid gland, we have these little glands that are very, very tiny. It's kind of like tinier than what my surgeons say is tinier than the 1 grain of rice. They're very tiny. It's located on each side of the thyroid gland. So these parathyroid glands are responsible to regulate your calcium in the body. Now, if we have an enlargement or a tumor of the parathyroid gland, it's going to produce this hormone that we call parathyroid hormone. And this hormone, what it's going to do is regulate that's basically the function of this hormone, regulating your calcium in your body. But what happens is that it's so overly activated that it's trying to take calcium out of everywhere it can, and it's mainly the bones. And because of that, we see some osteopenia, osteoporosis associated with that. Usually when we have somebody with MEN1 that have this condition, we recommend surgery, and usually the surgery is to resect 3.5 glands, because we know that in MEN1 all of the glands are enlarged. So that's the reason why, and they can be overactive, and that's the reason why they need to resect 3.5 glands for that. So now the other clinical manifestation associated with MEN1 is pituitary adenomas. Nowadays, I think they wanted to also call pituitary tumors also a neuroendocrine tumor, and nowadays they want to call it PITNET, PIT neuroendocrine tumor. And these occurs in approximately 15 to 42% of all patients with MEN1. As I discussed earlier, when they're functional, meaning that they produce hormone, the most common hormone that they produce is prolactin. But there are other hormones that can produce another hormone, is growth hormones, and that growth hormone excess. It depends whether you are in development, because we know that MEN1 can also occur in children as well, and we have seen as young as 15-year-old with a pituitary tumors that is producing growth hormones. If that's the case, this excess of growth hormones can cause somebody to be very tall. So in patients, adult patients they already stopped growing, so there's still some, and they can have other clinical manifestations associated with growth hormones as well. And there's some of them may produce another that's very rare, is called adrenocorticotropic hormone. So I'm putting this picture because that's what your pituitary gland is. So if we put like imaginary line, kind of like in the center of the brain, that's where your pituitary gland is sitting. And this gland is responsible to regulate every hormone in your body. This hormone sends a signal to different organs, like the thyroid gland, like the adrenal gland, the ovaries, to then secrete specific hormones associated with that organ. And MEN1, like I say, they can also produce these pituitary tumors, and because we say like this gland is the mother of all hormones, they can produce certain hormones as well. The clinical manifestations as well as the treatment is like any other pituitary adenomas. There is no difference whether how we treat sporadic pituitary tumors versus MEN1 related tumors. Now let's discuss a little bit about the pancreas and GI neuroendocrine tumors. That's the second most common manifestation associated with MEN1. Up to 80% of patients with MEN1 may have a pancreas or small or gastrointestinal neuroendocrine tumors. They can be functional tumors, as we discussed. They can be functional, another word is secreting tumors, because they can produce hormones. The most common hormone that can produce is gastrin, and we call those gastrinomas. Another name for that we call Zollinger-Ellison syndrome, because of the symptoms associated with the excess of gastrin, which regulates your acid in the stomach, and if there is excess of acid in the stomach, it may also explain why patients with gastrinoma may have peptic ulcer disease, ulcers, diarrhea, and some of this can bleed as well, and that's one of the reasons why these patients may go to the emergency room or so forth, because they have a bleeding ulcer. We discussed about insulinomas as well, and there's other hormones that may be produced by the pancreas, neuroendocrine tumors associated with MEN1, but these are super rare. And then, of course, we have the non-functional tumors associated with MEN1. And Zollinger-Ellison syndrome is always in the duodenum. That's all, and very, it can happen in the pancreas, but that's not very common as in the duodenum. And like I said earlier, 25% of patients that have the diagnosis of Zollinger-Ellison syndrome may be associated with MEN1. So when we see that, so MEN1 testing needs to be done. So these are the different medical management for the hormone excess associated with MEN1, and the recommendations are going to be the same as the sporadic neuroendocrine tumors, and you're going to hear a lot about this throughout the conference too. How do we treat neuroendocrine tumors? But just to mention here, in terms of the functional neuroendocrine tumors, because those are the ones that are associated with multiple endocrine neoplasia, if the patient has a gastrinoma or Zollinger-Ellison syndrome, we need to first control the excess of acid production, and we usually use high doses of these medications. We call that proton pump inhibitors, such as omeprazole, pantoprazole, lansoprazole. Sometimes we recommend that they have follow-ups with the gastroenterologist, so that way they can measure the acid output, and based on that they can make recommendations about any changes on the medications to control the acid secretion. And in the setting of more advanced or metastatic, because we can see that with gastrinomas, then we use a somatostatin agonist such as lanreotide or sandostatin, and you will hear a lot about that as well. When do we use it? How do we use it? Those are the monthly injections that we were discussing earlier with Mrs. Kex. And then we have insulinoma. We discussed that these patients with MEN1 can produce insulinoma, excess of insulin, and we need to control those symptoms too. More important, because whenever they present these two, we see these symptoms associated with these neuroendocrine tumors, they can be diagnosed earlier, that can be resected surgically, but we have seen the situation that they're more advanced, for which other interventions needs to be done. So dioxazine medication is used in order to control the hypoglycemia, so because it prevents the insulin secretion from the pancreas, and that's the reason why we use this medication. And we discuss about the somatostatin agonists such as lanreotide, sandostatin, or everolimus is used in more on the advanced settings. And the reason why we use everolimus is because this medication can cause high glucose levels. And because this medication can cause high glucose levels, sometimes we use that in this situation as well. So now in terms of the thymic and bronchial neuroendocrine tumors, we have seen an increase in incidence in patients with MEN1. Now we see that up to 8% of all patients with MEN1 may have these thymic or bronchopulmonary thymic neuroendocrine tumors. They're usually non-functional. I know that some of these, you will hear throughout the conference that some of these neuroendocrine tumors may secrete some hormones. But in this situation associated with MEN1, they're usually non-functional, non-secreted, and they don't produce any hormones. And in terms of the bronchopulmonary neuroendocrine tumors, it can occur in less than 5% of patients with MEN1, and it can also be a non-functional. And some of these, whenever it can be a functional tumor, or whenever, even though it's very rare, it's not like the sporadics that we see a little bit more higher compared to the MEN1-related thymic and bronchial neuroendocrine tumors. When it happens, it can either produce serotonin, and that can also cause carcinoid syndrome. It can also produce this hormone, which is called ACTH, and not to go into details, but this hormone, it sends a signal to the adrenal gland to produce cortisol, and if there is a lot of ACTH, then there is going to be a lot of cortisol in your body, and that translates into a syndrome called Cushing's syndrome, and that's what we have here. Now, how do we continue follow-up in terms of imaging for neuroendocrine tumors? We need to, whenever we suspect a patient with MEN1 may have a neuroendocrine tumor, we need to first do anatomical imaging studies, either with MRI or CT scans. Based on the findings, then we need to obtain a functional, what we call functional imaging studies, which it could be either a gallium or a copper dotted scans to rule out any evidence of neuroendocrine tumors that can correlate with what we see on the anatomical imaging studies, or it can also help us visualize other tumors that we're unable to see on the CTs or MRIs. And the question is, like, when do we start any type of screening or imaging studies in a patient that has MEN1? And there is not really any guidelines that helps me when do we need to start screening. Some other institutions, at least in my institution, were very aggressive with screening, and we start very early. But usually it can be postponed until the age of 16. But we need to do routine biochemical, meaning with hormones for the parathyroid, like parathyroid hormones, calcium, and other hormones that we can check as well. And that can also be done every year, or it could be every 2 or 3 years, depending on how the patient is presenting. So there are other tumors, we call it non-classical tumors associated with MEN1. We recognize those. We discussed earlier about the 3 Ps, but we know that there are more tumors associated now with MEN1. Some of them is adrenal tumors. Most of them, adrenal glands, are these little glands that are on top of the kidney, and these little adrenal glands are responsible to secrete hormones. They can secrete cortisol, they can secrete aldosterone. Aldosterone is the one that regulates your salt and water in your body. They can also produce your androgens. So there is another way to say these adrenal glands are responsible for salt, sex, and sugar. That's what they do, salt, sex, and sugar. And that's usually what these adrenal glands are responsible for. And sometimes they can produce a tumor, but in MEN1, these are very, very benign, but a small percentage, very rare, that may produce some malignant tumors associated with these adrenal glands, which is called adrenocortical carcinoma, but that's very rare. They can have other clinical presentations, such as this cutaneous tumor. We can see this, like these angiofibromas. This is the lip, underneath the lips. Then you can have these other clinical manifestations, skin manifestations called cholangiomas. Those are also part of the non-classical, but they can also be seen on MEN1 patients. And we discussed earlier, and we know now that breast cancer needs to be screened in patients with female patients with MEN1. It has been reported to almost double the risk of breast cancer. So that's something that we need to also check as well. So who needs to be tested for MEN1? So we discussed, I told you about the clinical manifestations for MEN1. So now who needs to be tested? So any index patient with clinical MEN1. So any patient that has the clinical manifestations of MEN1, which it could be 2 or more primary MEN1 tumor types, which we know is the 3 Ps, right? Pituitary, parathyroid, and pancreas. So any of those 2, that can also be considered clinical MEN1, and that needs an indication to be tested for MEN1. Also, patients that are known to have MEN1 or first-degree relative of known MEN1 mutations carries, irrespective of whether they have any clinical manifestations of no or related to MEN1, or even if they're asymptomatic, it still needs to be tested if they have family first-degree relative with MEN1 mutations. And also, individuals with suspicious or atypical MEN1, any patient that presents with any of those tumors that we discussed at a younger age, and they also present with multiple parathyroid tumors or gastrinoma, as well as pancreas neuroendocrine tumors at the early onset as well. Those needs to be tested as well for MEN1. And why that? Why that matters? Because based on that, if somebody has MEN1, even though there is no really standardized guidelines, and there has been some MEN1 experts that have established how we need to follow those patients, it's important to understand who may have MEN1. Based on that, then we need to start different screening based on the hormones that's a panel, because we discuss a lot of these tumors related to MEN1 may secrete hormones. And we discuss about the parathyroid, the hormones that regulates the hormone in the body. So we need to check calcium and PTH, and that can start as early as age of 8. We don't need to do any imaging studies. The only patients that may require or may recommend any imaging studies is for those patients that have we're following for any pituitary tumors, and the hormones can start to be checked at the age of 5. But then we can do MRIs every 3 years. It's not something that can be done every year. And these are for patients that have MEN1 carriers, meaning that we needs to follow over time, not necessarily that they have active disease, because once they have active disease, the follow is a little bit different. So just in terms of MEN1, we carefully monitor all patients with MEN1, non-MEN1 mutation carriers, and risk family members. We do not carry status for symptoms or size of MEN1 associated with tumors. We discuss about patients with how do we follow these patients with MEN1. We need to follow calcium, PTH, parathyroid hormone levels, as well as prolactin. That needs to be done every year to detect any patients that may detect any asymptomatic hyperparathyroidism. So that's the condition of excess of parathyroid hormones that we discussed earlier, associated with in the parathyroid glands, as well as prolactinomas from pituitary tumors. We discussed that pituitary tumors can also produce this excess of prolactin, and that's the most common hormone that we see in MEN1. We also need to discuss other hormonal levels, as well as imaging studies that we discussed earlier. And then, as we discussed, there is not really any protocols that tells me how we need to follow those patients over time. Every institution may do things a little bit different. Here in the United States, also depending on what insurance is able to approve based on the information that we have. At the NIH, we follow these patients very, very closely. But there is no really any, the quality in terms of, how to follow these patients is still upcoming or very poor today. And the treatment for these patients is very similar to any other sporadic neuroendocrine tumors that may not be associated with MEN1. Now, let's discuss about FHEO para. How much time do I have, Bob? Okay. Mm-hmm. Right. So we'll discuss about FHEO para. I don't know if any of you here may have FHEO chromocytoma and paraganglioma. Anyone? Because based on that, I can go more in detail or not. So I just want to make sure anyone has FHEO para. No? Okay. Okay. Just in terms of pheochromocytomas and paragangliomas, it's a continuing process. So there is still a lot that we're learning about these tumor types based on the genetics. If I mentioned earlier, the pheochromocytomas and paragangliomas are the ones that is 45% of those patients may be associated with a germline mutation. Compared to the neuroendocrine tumors we discussed, is about 10% or so that may be associated with cancer predisposition syndrome. But FHEO and PAR is a little bit different because about 45% may have a germline pathogenic variant. And that's important because based on that we have a different screening and follow-up and so forth. We have been advancements of how do we diagnose these patients with pheochromocytomas and paragangliomas. And then in terms of imaging studies, we'll discuss that in a little bit more in detail. Now moving forward. Okay, here. So now, so these are, I think I mentioned to you earlier that the adrenal glands are on top of the kidney. They're very, very tiny glands. And if you cut the adrenal gland in half, it has two layers. One is the outer layer, remember, salt, sex, sugar. But the inner one is the one that produces the adrenaline. So it's the fight and flight response. So, and again, usually we don't see if some of the questions, can we have tumors in both of the layers? It doesn't happen. Either the tumors are arising either for the outer layer of the adrenal gland, it's called the adrenal cortex, or from the adrenal medulla. And the adrenal medulla is the one that, again, produces this excess of adrenaline, and a tumor that produces excess of adrenaline that's called the pheochromocytoma. Pheochromocytoma is in the adrenal gland, but we also have these nerves outside the adrenal gland, because the adrenal gland also comes from this central nervous system based on evolution and how we are conceived and the embryonic differentiation. It comes from the central nervous system, this little part. But also we have nerves all around, all the way from the neck all the way down to the pelvis. And any tumor that is outside the adrenal gland is called paraganglioma. They are the same. Looking under the microscope is the same. They both can produce excess of hormone or excess of adrenaline. It's just that depending on the location where they are, whether it is in the adrenal gland, which is called pheochromocytoma, or outside the adrenal gland, which is called paraganglioma. So in terms of paragangliomas, they can be divided into two different paragangliomas depending on what they are. Now we discussed about PHEOs, top of the adrenal gland, it's in the adrenal gland, so which we say is on top of the kidneys, and those accounts for most of the pheochromocytomas and paragangliomas. But then 20% or so of all these PHEOs and paras may be paraganglioma. And that can be in two different we describe in two different categories: the ones that are in the neck area, and the ones that it could be anywhere from the chest, abdomen, and pelvis. Now, in the neck area is very different than the ones on the chest, abdomen, and pelvis, because in the neck area, these tumors, they don't produce hormones. They just grow, but because it's very small in the neck area, they can produce complications. But the ones that it could be anywhere from the chest, abdomen, and pelvis, these can definitely produce hormones too. And those, we call those secreting paragangliomas or functional paragangliomas, and those are the ones that produce, the hormone that is related with fight and flight response. Okay. So, and this is in terms of the paragangliomas, just to mention, most common is in the abdomen. This is the abdomen, and the most common location is in this area. We call that the bifurcation of the aorta, and that's the most common paraganglioma. When it's localized, it's most commonly seen there. But again, it can also, we discussed, it could be also localized on the head, as well on the thorax, as well as in the pelvis, but most commonly it's in this area where we see the paragangliomas. So what is the clinical features of pheochromocytomas and paragangliomas? And I'm sorry about this picture, but I do want to explain why this is important, because patients that are on the flight and fight response, can you imagine this excess of adrenaline? What happens whenever we're scared? We sweat, our blood pressure can go up. When we're stressed, our blood pressure can go up. So these patients with this excess of adrenaline, that's what happens all the time, 24/7. They have the blood pressure goes up, they sweat all the time, their heart rate goes up. So this is one of the things that happens constantly. And there is a lot in the literature, they call these tumors the great mimickers, because it can reflect anything. And a lot of the time, these patients are misdiagnosed because they think that it's anxiety related or menopause. If there is a female in the 50s or 60s having sweating and headaches, they say, well, that's menopause. And that's the reason why, this is one of the most misdiagnosed tumors here. And what happens is that these adrenalines, they have these little receptors, these little particles that goes into the vessel. So this is the tumor cell that is releasing a lot of adrenaline, and then it goes into the vessel. And when it goes into the vessel, it causes vasoconstriction. So that's the reason why the blood pressure can go very, very high. And one of the things that we need to do whenever we have the diagnosis of pheochromocytoma that is producing hormone, we need to block that. And there are medications for that. So there are also certain situations that can exacerbate those crises, those excess of adrenaline producing symptoms. There are certain things that can exacerbate it, and that can be having a strenuous physical exertion, sometimes by having some changes in position, as well as eating certain foods like cheese and bananas and caffeine. There are certain drugs that can cause this hypertensive crisis or adrenaline crisis, like the steroids, drugs as well. surgery as well as anesthesia. Some patients they need to have a colonoscopy, and when they do the colonoscopy, they require anesthesia, the blood pressure goes very high, and that's kind of like sometimes how these patients may are diagnosed as well. Once we prescribe any therapies to these patients or recommend any therapies, these type of therapies can also cause killing the PHEO cells. There is a release of these hormones, so we need to make sure that can also cause hypertensive crisis. So those are the things that whenever this happens, we need to make sure that these patients have the right medication to prevent that, and we'll talk more about that. As we discussed earlier, most of the pheochromocytomas and paragangliomas, up to 40% of these patients, even 45% in some other in the literature, may be associated with a germline pathogenic variant. Most of only 25% of all PHEO may be paragangliomas. Remember, paragangliomas is outside the adrenal gland. And approximately 25% may be malignant, meaning that can go to other places, and approximately 10% can be also bilateral. So one thing that I want to mention, even as when I was in medical school, we learned the rule of tens for these tumors, because we'd say it was 10% malignant, 10% was hereditary, 10% was bilateral. That's still the same. But now we know with the genomics of understanding the genomics of these tumors that that's no longer the case. Now, in terms of hereditary syndromes associated with MEN1, with pheochromocytomas and paragangliomas, as I mentioned earlier, multiple endocrine neoplasia type 2A or 2B is associated with pheochromocytoma. They have other endocrine tumors. MEN2A has the parathyroid, also has the medullary cancer as well as the pheochromocytoma. MEN2B has the medullary cancer, the pheochromocytoma, but also they have what we call, they're very tall and skinny. We call that Marfanoid habitus. Neurofibromatosis type 1 is also associated with, has pheochromocytomas as part of their clinical manifestation. They have other clinical findings associated with NF1, and neuroendocrine tumors, pancreas neuroendocrine tumors is also one of them. So a patient with NF1, neuroendocrine tumors, or pancreas neuroendocrine tumors is part of the syndromes, and we need to screen for that as well. They also have very skin findings, we call this scaphoid spots. They have eye findings, we call that leaf nodules. They have the skin manifestation, we call the neurofibromas, but they can also have pheochromocytomas and pancreas neuroendocrine tumors. Von Hippel-Lando is another cancer predisposition syndrome associated with pheochromocytoma. The association of von Hippel-Lando is about 50% of patients with VHL may have pheochromocytomas and paragangliomas, and they can also have bilateral tumors as well. But they also have other clinical findings associated with VHL, like the hemangioblastoma of the eyes. It can affect the central nervous system. It can also have kidney cancer associated with VHL. Pancreas neuroendocrine tumors is another clinical manifestation associated with the VHL. Now, I don't know if any of you heard about the Sultifen. So the Sultifen is approved for VHL-related tumors, mainly for kidney cancer, CNS hemangioblastomas, as well as pancreas neuroendocrine tumors, but it's not approved for pheochromocytomas in this situation. And then we have the hereditary paragangliomas, which is caused for another series of mutations here. But the reason why this is more important, because this is the one that is associated with the highest risk of malignancy and metastatic behavior. So these are the ones that metastasize. 45% of patients that have metastatic disease may have a succinate dehydrogenase mutation associated with these tumors. So I know this is very complex, but this is just for you to focus only on the timeline. So as you can see here, we have learned a lot about these tumor types until now, and that has been based on the discoveries of different mutations associated with these tumor types. This is kind of like the names of the mutations, kind of like saying MEN1 or VHL, but these are the different mutations associated with these tumor types that help us understand more about how these tumors behave. And based on that information, we think that based on what tumors they have, we may be able to personalize therapies, different therapies for these patients, but that's a work in progress. Genetic counseling. All patients diagnosed with pheochromocytomas and paraganglioma should be referred to genetic counseling. 30 to 40% are hereditary. It can also help us guide surveillance in patients and their families. It can also establish risk for develop other pheochromocytomas or paragangliomas, recurrence, metastasis, and other associated tumors as well. When to suspect PHEO-para, signs and symptoms of catecholamine excess, high blood pressure, high heart rate, elevated heart rate, nausea, sweating. Those are the headaches, the symptoms associated with catecholamine excess. With this increased blood pressure when it's caused by certain medications or anesthesia or during surgery. Unexplained blood pressure variability. Some of these patients have very low blood pressure and then very high blood pressure. Difficulty controlling the blood pressure despite 3 or 4 different medications. Family or personal history of pheochromocytomas and paragangliomas or any other cancer predisposition syndrome that is associated with pheochromocytoma. We discussed ponticolando, multiple endocrine neoplasia type 2A and B, and NF1. Biochemical diagnosis, we usually diagnose with either a plasma methanoephrine or a urine. So when it's in urine, it's 24-hour urine collection. I know because for our neuroendocrine tumors, sometimes they like to collect 24 hours for 5-HIAA. So we also do a 24-hour urine collection for catecholamines. But it can also, originally we ordered a blood test and we see that the plasma methanoephrines are elevated. If we see that it's 4 times upper limit normal, that's suggestive of pheochromocytomas. There are certain things that we need to stop, certain medications that we need to stop whenever we run the study, just because they can cause false elevation of these hormones. I just want to go a little bit more rapidly because I do want to go with some of the work that we're doing at the NIH, so just for you to be aware, which is more related to the neuroendocrine tumors, but these are different hormones that we check in a patient with pheochromocytomas and paragangliomas. These are your methanoephrines and these are your catecholamines, and I'm sorry, some of them may be something that is you're not very common to see, but it's just for patients with PHEO-para. We need to make sure that we check those levels too, either in blood or in urine. We also localize, similarly to other neuroendocrine tumors, we obtained imaging studies either with CT scan or an MRI that help us understand more detailed pictures of what's going on inside the body. Like this one is a tumor in the adrenal gland, and this is just kind of like the different, you're maybe familiar with this, with the CT scans or the MRIs. And we also use a functional imaging modalities. That's either a 68 gallium dotatate scan or a copper scan. Actually, we like those scans for pheochromocytomas and paragangliomas because the way they're able to detect the tumors is very high. But there are also indications because we also understand that sometimes insurance may not be able to approve it in certain situations, so that's why we kind of like understand, we make recommendations to obtain either 68 gallium or copper dotatate scan based on what we see in a patient with pheochromocytomas and paragangliomas. All paragangliomas needs to have a copper dotatate scan because it can also be in many different places. Any pheochromocytoma greater than 5 centimeters in size because that has a higher risk of metastasis. Any patient with recurrent metastatic disease. And as well, it can also, these scans help us to determine whether the patient may benefit from treatment either with Lutathera. I'm sure some of you may be familiar with Lutathera. In order to receive Lutathera, you need to have a positive dotatate scan and as well MIBG. And this is just different functional imaging modalities that we see for the pheochromocytomas and paragangliomas. And you can see the dotatate scan. This is an example of dotatate scan. Is very good for a patient with pheochromocytomas and paragangliomas compared to other scans. We're not going into detail about this. I just discuss that a dotatate scan is better to detect lesions in a patient with pheochromocytomas and paragangliomas compared to FDG or MIBG. It's important we discuss about the excess of catecholamines that we need to treat those patients accordingly. We need to add, there are different medications that we need to prescribe for those patients. We discuss about very important to give the medications that block those hormones that goes into the blood vessels. Those called the alpha blockers, and there are the different types that we can use. And after we use this medication, there are other medications that we can use to control the blood pressure in those patients and symptoms associated with adrenaline excess. And once this is just the surveillance, once the pheochromocytoma and paraganglioma is resected, if we don't know that there is any mutation associated with pheochromocytoma and paraganglioma, we still recommend lifetime and annual biochemistry. I know that sometimes what we have seen is once the tumor is resected, they don't follow those patients, but that shouldn't be the case. So we definitely need to recommend lifelong biochemistry in those patients and consider imaging if the tumor is greater than 5 centimeters in size. For FAMILIAL and Paragon related to von Hippel-Lando, NF1 or MEN2A or B, we still recommend also to have every year the biochemistry for metanephrines, as well as any other recommendations based on their cancer predisposition syndrome guidelines. And if there is succinate dehydrogenase mutations, they also, in this situation, because we know that these tumors may be associated with more aggressive pheochromocytomas and paraganglioma and metastasize, we recommend more often not only the hormonal evaluation, which is every 6 months, but also full body CTs or MRIs every year or every 2 years. This is the different treatments. We know that the most metastatic pheochromocytomas and paragangliomas can be sometimes difficult to treat, but we have options that we can treat. But because I want to move to the what we're doing at the NIH, so that way you're aware that it also can be helpful in patients with neuroendocrine tumors. So this is what I'm just in the last 5 minutes. I hope I have 5 minutes. Yeah. So, and we know that the incidence of neuroendocrine tumors has increased as well in the last few decades, and we can see the different type also of neuroendocrine tumors that has increased as well over the years. But we know that we have challenges. We have challenges in the management of neuroendocrine tumors. We know that there are not that many FDA-approved agents. Sometimes we know sometimes we don't know what combination therapeutic approach we need to use. We sometimes don't know how long we need to use a specific therapy. We sometimes don't know what subgroup of patients, so it requires a very specific treatment option on what we should use whenever we see a patient with this, with the neuroendocrine tumors. And also, some of you will hear that neuroendocrine carcinoma, we need to develop better therapies because those are the ones that's the most aggressive and of the neuroendocrine tumors. And we feel that how we're able to answer some of these questions is by establish a comprehensive classification system that incorporates tumor clinical stage, genomic and epigenetic alterations, mainly all the genomic data, all the clinical characteristics associated with the neuroendocrine tumors. We also studied the tumor as well, the genomic of the tumors as well, to better understand the biology of these neuroendocrine tumors, because we wanted to correlate that with order to understand which patients may respond better to different therapies, and as well to correlate with outcomes as well. We also understand that patients with neuroendocrine tumors and their families face unique challenges because it takes a long time of diagnosis, and sometimes when they're diagnosed, the cancer is in advanced stages. We also know that most medical centers has limited experience with these tumors, and sometimes you have to travel long distance to see an expert in neuroendocrine tumors, and that's also a struggle for families as well. We also know that there's no really standardized treatment guidance, and sometimes that creates uncertainty as well. And patients can sometimes feel isolated based that we know these are rare cancers and so many questions that need answers. And because of that, we're trying to develop in our institution an easily accessible national and international patient network for neuroendocrine tumor research and patient care with advocacy support groups that will address the patient needs above and increase access to patients to research as well. And just to let you know, at my institution, I am in the National Institute of Health, we also wanted to help patients that are in an underserved area, and we are willing to help them as well to travel to our institutions and provide therapies as well. We also know that NET researchers, like some of us here, also have some hurdles to develop cure because sometimes it can take a long time to recruit patients into clinical trials. We sometimes need a multidisciplinary team and to care for patients with neuroendocrine tumors. Sometimes there is lack of coordination between teams, and that can also cause silos, and that can also limit efficiency to clinical trials. We also know that there is not many good preclinical models. I'm sure some of you may have heard that we need to develop better models in order to do drug testing that can help us develop better therapies for those patients. And of course, sometimes even for a net researcher, fundraising, and it can be a little bit challenging because there's less resources for those patients as well. So, and we're hoping that what we're trying to achieve is a collaborative effort that we have our institution that help us to develop that network to be able to do neuroendocrine tumor research and to be able to promote development of new therapies, as well as able to understand what standard of care options are more effective for these patients. So, and I know that I say a lot, but how in our institution, how we wanted to answer those questions. And we are fortunate to be the investigator of a natural history study for neuroendocrine tumors. We're also including now adrenocortical cancer. It was not there before, but we now include it because this is an orphan tumor and they don't have a home. So now some of these tumors are seen within the neuroendocrine tumor support groups. But we're trying to understand long-term the natural history of these patients. We are collecting our clinical data, demographic data, what patients, has been exposed as well. We also wanted to understand if there is any environmental exposure associated with these neuroendocrine tumors. We also wanted to understand of those patients who responded to specific therapies, and we're trying to correlate that with some genomic data that we're obtaining as well, to then correlate that with outcomes. This is something that we do our institutions. If a patient comes to our institutions, they come through this study, and then we are able to do surgery as well. And once we do surgery, then this goes to different places. So we take a small piece of their tumor, so they have surgery. And I have to tell you, Dr. Lou is a surgeon here, and I know that he's working hard and collaborate with others like me for the same purpose, to be able to develop better therapies. And Dr. Lou is also trying to help us as well to collect tissue to analyze it. But I'm sure he will agree that one of the questions that Dr. Lou has and others is like, yes, I can cut your tumor, I can remove your tumor. But then after that, it's like, what can we do for that? Can we help others by understanding what we see in the tumor? And that's one thing that others like Dr. Wall and Dr. Lewis we're trying to work together on that as well. But when any tumor that we get, it goes to different places. We like to grow them. We call this organoids, and then we do different drug testing. The goal is to see if we can find a signal that helps us to develop therapies. We're also trying to understand their tumor immune microenvironment, and based on what we see in the tumor immune microenvironment, whether that will help us understand more about the biology of these tumors, with the end goal to then develop therapies as well. And then we have a very, I have to say, cool tool at my institution where all the genomic data from the tumor goes into a machine. And that machine is helping me analyze all of the genes associated with neuroendocrine tumors, and then we correlate that with response of different treatments. We hope with that we'll be able to understand, hopefully, which patients may benefit from specific therapies that we can make recommendations later on. So since we discussed about FEO-PARA, we have an investigator at the clinical center that focuses, Dr. Carl Patzar, who is an endocrinologist. He focuses in pheochromocytomas and paragangliomas, and he also has his natural history study. And at the NIH, we also have a study with Lutathera for pheochromocytomas and paragangliomas. And finally, Dr. Wong, we were able to open the study. It took a little while, but we finally were able to study the Lutathera elaborate study for gastric and pancreas neuroendocrine tumors. So this is it took us some time to get it opened, and finally it's open. We're actively accruing patients, and this is a patient that we combined Lutathera with olaparib. So, and I'm sure you will hear them from Dr. Shahan, because Dr. Shahan and I were very good friends, and we follow the same principle that we know that Lutathera works for patients with neuroendocrine tumors, and Lutathera is a type of radiation that damages the DNA of the cells, and your body is trying to repair itself from that damage. So sometimes when that happens, we think, this is what we're thinking, is that Lutathera may not be as effective. But what about if we give something that prevents that repair? So we think that that can make Lutathera more effective. But that's the question that we want to answer, and that's the reason why we have this study ongoing. And Dr. Shahan has other studies, again, with the same principle, using other drugs as well. And this is what, just explaining about the what it does, the DNH damage, and the cell is going to try to repair itself, and there are different drugs and these PARP inhibitors. This medication has been approved for breast cancer, ovarian, prostate cancer, but this is what we use in order to inhibit that repair. Of this family of medications, we chose olaparib because we know more of the side effect profile compared to other ones. I'm also leading this study with Dr. Perez. This is also specifically for pheochromocytomas and paragangliomas. This is a randomized study. Patients either go to the temozolomide arm, or they can go into temozolomide in combination with olaparib. Same rationale as the PRRT and Lutathera and olaparib. Temozolomide is a type of chemotherapy, oral chemotherapy, cause damage to the DNA. And what we know is that, as I explained earlier, cell is going to try to repair itself, so we're trying to give something to prevent the repair to make temozolomide more effective. And that's the question that we would like to answer by doing this study. We're accruing this, actively accruing. This is a multi-center, so there are many centers around the United States that has the study open. At the NIH, we also have the Sultifan study. I'm sure you will hear more about that for pheochromocytomas and paragangliomas, but also for pancreas neuroendocrine tumors. And the reason why we wanted to use that drug is called the Sultifan is because pheochromocytomas and paragangliomas and some of the pancreas neuroendocrine tumors may have a stabilization of a protein called the hypoxia-inducible factor. And when that HIF is stabilized, that can promote tumor growth. So the Sultifan kind of like blocks that protein, so that way it can also kill the cancer cells in a way. So that's specifically for PheoPara. But what we know is that also patients with pancreas neuroendocrine tumors also has the mutation in the VHL. As I said earlier, the Sultifan was approved for VHL-related tumors, but there is a percentage, and the literature say about 40% of patients with pancreas neuroendocrine tumors may also have that mutation. But again, that's not something, it's not an inclusion to be part of the study, but that's the rationale why they wanted to do the studies. It's open in many centers throughout the United States. And then we also have the lanreotide. I'm sorry, no, this is axitinib. My apologies. I meant to put the lanreotide, this one. This is Dr. Fojo. We collaborate with Dr. Fojo at Columbia University for pheochromocytomas and paragangliomas. It's not axitinib. My apologies. I meant the lanreotide, which we use for neuroendocrine tumors, pancreas, and as well as a small bowel. But we wanted to also study if lanreotide can also be effective for pheochromocytomas and paragangliomas. A lot of the oncologists may prescribe that, but we don't have any data that supports that. So that's the reason why we're doing this study. So this is the Neuroendocrine Tumor Therapeutics programs at the NIH. So we have two natural studies for neuroendocrine tumors. We have ongoing clinical trials that we're actively accruing. And of course, I think you will hear from others that some of these tumors may require multidisciplinary approach for the management of these patients, but at the same time, even in my clinic, I may have like a little tumor board, so I may just call my surgeon, I may call Dr. Lou, and that's how we then discuss those patients to provide the best guidance in terms of their care. And with that, I just thank you for your attention, thank you for being here, and thank you, NCAN.